Okay, it says we're live. I don't hear any audio feedback just yet. We're just chilling in the front. And
maybe we should sit on the couch.
Yeah. So far, we don't hear any pushback.
Okay. Is it better, guys? Like, can we put it like...
Yeah. Let's see if we can do this.
Or maybe we can... Or how about like this? Hold on.
Perfect. Someone said yay.
Okay, yay. Okay, so we're just...
Awesome.
Oh, wait, hold on. Let's turn it so we get...
Oh.
Like that. And then
Yeah.
I'll scoot over and then you can come.
Hi, Dr. Justin.
Okay, so we are live now.
Third time's a charm.
Sorry, everybody. It's been a little bit cray today. You know what? I just got a new cover for my phone, and maybe it has something to do with the cover of my phone. Oh, good. Thank you.
With that pad put on too, that probably, right? Didn't you just have that fixed?
But maybe. I don't know. It was better for us, but now you're sounding a little bit bad. Maybe Ashley and I need to walk down the block.
You have it all.
I don't know. Do we have to be on Wi-Fi? I'm on Wi-Fi. No, do we have to be?
I don't know.
I'm
Wi-Fi. That makes a difference.
So now I guess I'm messed. Yes. I don't know. Can anybody hear me? I don't know. Hey, you're back.
The Dr. Justin show.
Is it better? You're all breaking up now.
Yeah, but hold on. Back on now. It froze for a while. Can you hear me?
Yeah.
Good.
Better.
Seems good on my end. How's it sound, Phil Barnhart? How's everything? We're doing audio.
Is it better
I
now?
think it's better.
Mom says no, but I don't know what she's saying no to.
Okay, well hold on. We're gonna make one more move. Come on. Ashley and I are gonna move right back
Sounds like
to the other room where our reception is better.
Taking this party on the road.
I knew we should have gone to my house.
There's a wine there too.
Okay, is that better?
you guys are great on my end. It's not a problem. How's everybody? Can anybody say a yes?
It says we're both breaking up now. No, that's our camera. What is a disaster? Listen, if you just want to get this sucked out, just come and get it sucked out.
Alright, so Mom says it's not good. I mean, it seems
It's not
Us-
good.
Okay.
Oh, man.
We'll take a rain check.
or we could just go live on one and then you can just ask me and I'll just
Yeah, what if we just come back there?
yeah.
Okay, we're coming to you. We're coming to you. Actually, you come here.
I mean, my reception's great over here. I got the window and everything. All right.
Okay, so we're gonna so
All right, so we're gonna hear us. Bye. So I think we have to disconnect because it's not happening.
Hey!
Hey. We're Uncle made
Is
it.
it working?
No,
Actually, you sound better.
no, everything sounds
You
great
guys
on
sound
our end.
great.
Yeah, but
But how do you sound when you talk?
You guys sound perfect. It sounds good in here.
But how does your voice sound?
Good.
So everybody's joining it. You know, I want to know if they can hear us okay.
Maybe they just wanted us
Let's
together.
just go with it.
All
Let's
right.
just go with it.
Yeah, so is the sound good, everybody?
Yes.
Yeah.
Okay, awesome.
Okay, sounds
Okay,
great.
perfect.
I don't know what happened.
Maybe you just put us together. Boo.
Aw.
So we're talking about precision sculpt.
All right, so yeah, so we're talking about precision sculpt, which is our liposuction technique, which is very unique and advanced, and has taken
And how is
a
it
decade
unique?
or
How
so.
is it unique? What's
Oh,
unique
where do
about
I
it?
start? Where do I start? Well, I mean, for patients that don't know, and a lot of patients I think that are on here know about it, but you know, it's first off, it's done awake, right, without the use of general anesthesia, which is a huge part of it, because if you don't need to be put,
No,
Ashley's breaking
breaking
out. If you don't need to be put to sleep, then don't do it, right? It's not necessary. With good numbing technique, you can do a lot of stuff on the body without the immunosuppressive effects of general anesthesia and all the risks that go with that. I'm saying general anesthesia can be done, but it doesn't need to be done for this type of procedure, and for many reasons also besides the risk component, but the just time spent. So I love to spend a lot of time, as everybody knows, with
Talking.
yeah, talking with
Yourself?
my patients during the procedure, because to sculpt, which this is sculpting, okay? To do that, you have to spend time taking it down very smooth, very evenly. You can't just go in there and whack out all the fat, which is what typical liposuction approach is, and that's the way a lot of docs do it, and that's why there's a lot of bad work out there, and not that they want to do bad work, but it's just they have to move quickly. It's under general anesthesia. They gotta get out as much fat as possible, so they wake the patient up and get him moving. That situation doesn't allow for really good, fine end results. So you got to spend a lot of time. So I spent a good 4 or 5 hours today. I think we spent 5 hours, maybe more, on the arms, back brow rolls, waist tips, and then transfer to the butt. While other docs will take 2 hours to do it, there's a difference when you're spending time sculpting something.
So when you talk about the arms, where exactly do you lipo down here? Is it up here? Where exactly? Is it this stuff hanging down?
So technically arm, right? So arm is this area, right? Because this is the forearm, right? So this is the arm. Now that's why we say arm. I mean, if you were referring to this whole thing, it's upper extremity, just technically, okay? We don't do any lipo of the forearms here. There's really not good fat to take from here. So when I'm doing the arms, it's from essentially the elbow all the way up to the crease, okay? And I come up nice and high onto the front of the bicep, and I come up really nice and high on the back of the tricep here area. So essentially kind of the only place I don't do is right over, there's a little strip right here. It's almost a 360 arm, but I find that you really got to come up nice and high up into this zone to really get a nice result, because most of the time this area is what's bugging everybody. Some people have some fat down here, but it's mostly up in this area here. When I do it, just so you know, because I make 2 little tiny incisions here and 1 in the crease here, and that allows me to come at it at multiple different directions. And most surgeons, or I see a lot of docs, place 1 incision right here, or they'll place 1 right here. Occasionally I'll see 1 in this area, but it's usually kind of off to the side, and it limits how much they can get it done. So typically arm results outside of here are very minor. Most patients come if they've had it done and they say, I don't notice any change, right? Because the access point was bad, and it's just the experience of the surgeon. So that's it with the arms.
And what about, how do you know if they have this
the jiggle?
dangling?
Yeah.
How do you know if you need to cut the skin out, or can you tighten it? And how do you tighten it?
So that is kind of the holy grail, right? Is everybody wants their skin as tight as possible.
Yeah, because I got this.
Essentially, if I came to me and was like, hey, I want my arms smaller, right? I wouldn't be a good candidate, because as you see, when I pinch, there's hardly any subcutaneous fat here. There's muscle above it, and that pinch is very small,
Bragger.
right? No, I wish.
I got a
wish.
lot. Let's talk
It's
about
getting-
my arms here.
it's getting loose. But you know, for me, there's this is all skin. So if I would say like, oh no, I have to have smaller arms. It's, you know, I want something done, please, whatever I can get done. There's two options. One would be just heating the tissue with our Renuvion underneath the skin to cause contraction of the tissue. And in my case, that would result in minor changes. Okay, it's not really hanging down. But you'd have to remove skin. I'd have to make an incision across here, cut out skin, and stitch it up. Okay, and obviously that's not something I need. But that would be, you know, in the case where there's no fat. Now most people come in and they have fat in that area. Some people have a lot. Some people have a little bit. And I can essentially make a change on everybody as long as they have some fat to take. It's just how much of a change, and we go over that in person. Obviously, when I grab a hold, if that pinch was, you know, 4 times the size of that, then I can shrink it down by a good half of that size. So you got to have some fat to take here. And when you take the fat, if there is some looseness to it, this is a great area where we use the Renuvion. Which is radio frequency. It's placed underneath the skin, and it heats that space where the fat was, and it causes it to contract in. I tell patients it's not a miracle. It's not the same as if I cut skin out and stitch it, but it's the bridge between doing nothing and cutting skin out. And so it helps contract in that space, so it pulls the skin tighter. It doesn't take your skin and overly pull it, but it does help it conform around that new, smaller volume, essentially.
I have a question.
Just one?
I say every second like that. How hard is it to fix bad lipo or lipo that's maybe gone wrong? Because we see that a lot. We actually see a lot of patients who come in and they say, I want to the Dominican, or maybe they cut corners on cost, or whatever the case may be. They come with bad lipo, and we're supposed to fix it.
So you know, every patient's different. So we call it revision lipo, right? And they come in all different forms. Sometimes the patient comes and they had very little taken off, right? And so they have a lot of residual fat, and they just want to get the results that they were hoping for because the doc didn't take enough off of them, right? They come in with areas that are over resected compared to the adjacent zone. So they have some irregularities with some fat still there, but they are uneven. One waist is not as sculpted as the other, or the lower abdomen, the front of the abdomen, the tummy, underneath, below the belly button has been brought in a lot, and the part above it hasn't been, like above the belly button, so they have discrepancies. You know, irregularities in general. Are you looking to say something? You're huffing and puffing. But what I'm saying is, it's not always the same. I mean, and it's just been done irregular. You're leaving, so you're distracting me. Yeah. Out.
Bye.
So you know. All fat, right? And there's irregularities, subtle irregularities, but now it's mostly due to scarred areas. Some areas more scarred than others, and it's just down to thin skin. Those are challenging patients because sometimes there's not an option for them other than, like, if it's the abdomen, like a tummy tuck, and that's sometimes it's not something that patients want to get into. So I mean, the most important thing is getting it done right the first time, right? You know. And if you can't, you've already had it done and you can't, you know, have that as an option anymore, then, you know, we come and see what we can do to help smooth things out, take things down further in areas that still have bulging fat, and sometimes even transfer to zones to move that fat from one place to an area where there's an irregularity to help achieve a more, you know, smoother result.
If somebody wanted fat transfer, where is the best fat taken from? Like, say you want to fat transfer the face, or fat transfer the hands, or the breast. What area of the body is the fat the best to take from?
So first off, it should be a virgin area, so meaning it's never been touched before, ideally, right? So like they've never had lipo in the area that I'm going to be taking the fat and transferring it from. because when you have lipo before, there's some scar tissue in the area, and the fat cells just aren't as robust. So we want to pick an area that hasn't been touched before. Now, if a patient comes in, which most patients come in and they haven't had any lipo done before on their body, now what is the best area? Typically the tummy, the abdomen, stomach area, and the front is great donor. The waist, the love handles, that lipo 360 and fat transfer to the butt is great, the great combo, because it offers really nice, robust, healthy, stubborn fat. And it also complements the enhancement of the butt. When you get the waist brought in and the butt brought out, it really magnifies the reshaping. If they don't want to have their abdomen touched, or they've had it touched and they're like, hey, I still want fat transfer, I find the inner thighs, the inner knees, so this whole section here.
Wait, can we see that again?
The bar of fat, so to speak, and arms are nice here. Areas that don't really offer great fat is kind of this front bra roll and the back bra roll. It's more fibrous in that area, and it's just robust, high volume of fat. I do use that sometimes if that's all we got, but it's not my preference. If it's just fat transfer to the face and we're not looking to sculpt the whole body, we'll take it from a small zone, either outer thigh or inner thighs, or the inner knees, or even just the lower part of the abdomen, but ideally from areas that are untouched.
So what about taking the fat from the chin and neck and transferring it like to the lips or something like that? Is that something that can be done?
I said all the doing my chin and neck. Can I transfer it to my butt? Right? And for me, I'm like, of course not. It's not enough. But the quality of the fat in the chin and neck, even in the heaviest necks, it's kind of chunky. It's bloody, not a lot of it, but it's bloody, it's fibrous, it's not nice, smooth fat. You want something smooth as possible, especially for your face. And so the chin and neck just does not offer good fat to transfer. So I never use that. It always gets discarded because it's never high volume and it's just not good quality. And you don't want to put, bad quality fat into an area and hope for the best. It's not a good approach.
Of all the different areas to transfer to, the face, lips, breasts, hands, or butt, which area seems to be the most receptive to receive fat?
I'd say the butt is number one. So the butt for sure seems to take more than anywhere else. But at the same time, it also the most volume, right? It has the most room. So you can put in, 500, 600, 700, 800 cc's of fat, which, we're talking a half a liter, you look at a 2 liter of Coke, right? And essentially you're putting a half a liter into each butt. That's a lot of volume, right? You can't put that kind of volume in the face. You can't put that kind of volume in the breast. So it receives a higher volume, but at the same time seems to take it as well. So I'd say butt is number one, and then followed by breast. And breast can be a little hit or miss, and so I never overpromise with breast. Usually it's about a half a cup, maybe full cup max with a transfer. I think that's realistic. But it's not like the butt. You can go from kind of a flat butt to bam. You can't do that with the breast. It usually takes multiple sessions. So the answer to your question is butt.
And would you transfer fat around breasts if someone has implants already?
Yes, and we call that, if you're doing actually from the start, you're doing a breast implant and fat transfer at the same time. We call it a composite breast augmentation because it's a mixture of implant and fat placed in different parts of the breast. But if you have a patient who has breast implants and they don't want to upgrade the size, or they want to have a little more cleavage or a little more upper part of the breast fullness, or they have some rippling from their breast implants, but the breast implants are sitting in a good place, they don't want to mess with them, fat is definitely the gold standard in giving more volume on top of the implant. It's not placed on top of it, literally. It's placed within the tissue that surrounds the implant. So you can really target the cleavage, the upper part, even the under part, and even sometimes the scars can. But the answer is yes. It's actually a really great procedure to further fine tune a breast augmentation, because an implant itself goes into one space, right, and it just kind of pushes the whole breast out, which works. You know, you get great results like that. But if you're lacking some volume in the cleavage or lacking some here, you're still lacking it even with an implant, and now you can target specific areas. So it gives a breast augmentation. If you're doing both, you can really take it to the next level.
Yeah.
And they want to do fat transfer to it. It's done here in the office. You're awake, you're relaxed. You don't need general anesthesia for that. There's very careful attention, special attention paid to the breast. I mean, I do it with every patient, but especially with an implant in place, you have to really be, skilled at placing it in the right place and not messing with the implant.
Do you see that question down there, Dr. Justin, where it says, can you replace the implant with fat?
Yeah, so yes, the answer is yes. So we remove the implants, okay, and then place fat. But now fat is not placed in the same place as the implant. You can't just put fat into an open cavity. It has no way to get incorporated into the tissue. It just will wind up kind of dying off, and it's not the right answer. So it's not the same as it's not an even exchange. You have to place it within the superficial component, essentially into tissue. So if we're removing, say, a 400 cc implant, which is common, so I say 350, but we'll just pick 400. You take out the 400 and you're putting in somewhere around 300 cc's of fat into the breast. Usually it's what we can get in, somewhere around there. It's not an even exchange, and you're going to lose some fat, which is about 50%. So, it's like you take out a 400 and you end up with about 150. So can you exchange? Yes. Is it the same result as having an implant? No.
Have you ever injected fat in someone's chin for a chin augmentation?
Yes, but very often. The answer is yes. I'm reluctant on it a little bit because chin augmentation a lot of times is bony in nature and firm in nature. And so you're augmenting the bone, and fat itself is not bone, obviously, and you can now have just kind of more of a fatty chin as opposed to a strong kind of firm chin. And I still think the fillers kind of reign in that arena outside of a chin implant itself. So I prefer to send them to you for a little filler, and I also think it's an area where you want to be kind of as precise as possible. There is some it's unreliability of fat, and since you put it in there and you have to really fill it out a lot, and then you're going to lose some, and so where it's going to get to is a little unpredictable. It's usually going to be less than what you want, and so if you just go with a nice filler, then you know exactly what you're going to get, and it stays there, and it's nice and supportive.
And what about fat in the forehead or other areas of the face?
Yeah, so we do a lot of pan-facial fat transfer, which works really great for the soft tissue, meaning the skin and the subcutaneous tissue. So across the forehead would be fine lines. So we break up the fat and we place it into the fine lines. It's very superficial placement. If there is a global kind of loss, then placing some thicker layer of fat. I know you're asking. Someone asked this for you, huh? Did you set them up? So I had one patient whose forehead was fairly collapsed compared to the other side, and we placed fat all across this area to help even it out. I mean, you can essentially place fat anywhere, in the body. It's your own stuff. So, when it comes to
How about the earlobes?
so I put it all over. So temple area, put it underneath the eyes in this junction here where I need it, so badly now. So the tear trough along the junction into the cheeks, so augmenting the cheekbones here. A lot of guys get very flat here, which I'm starting to get flat. So putting some volume here for males. Females really kind of get it across the whole way into the smile lines. I almost picked my nose. Into the smile lines, and then into the marionette folds, of course, across the lips. And even if it's too caved in this area, you can place volume throughout the face.
Dr. Justin, there was a question that someone asked, can perform precision sculpt on the ankle.
Yes. I mean, anywhere there's fat underneath the skin is really, you can have it removed. Now, when it comes to the ankles, I'm going to come up here. All right. Hold on.
Oh.
Watch out, this is a PG show.
Right down, don't see the ankle itself. So especially doing this, the back portion can help define the calf and also bring out the ankle. Some people have fat along the whole front of the leg here and also on this side. So doing this whole strip as well can help bring out the ankle. So I don't really do it below or distal, distal to the ankle. It's all kind of above. But yes, definitely.
And how long would that take?
How long is the ankle? Like if we're just doing the ankle itself, I mean, everything takes me, I'd say, 2 hours or more, right?
Yeah, minimum.
Yeah, it's about doing some sort of lipo. It's at least 2 hours. You're probably like 3, right? No, but if it's just ankles itself, it's about 2 hours, and then. And when we're done with it, you get wrapped up, right? You get your legs all wrapped up, and you're able to walk on out of here. But you got to elevate your legs, and I really try to say elevate as much as you can for at least a couple weeks. Try not to stand long periods of time, but you can get back into action fairly quickly.
And there's a couple more questions I want to make sure that we get to. How sculpted can you get the arms? Can you pronounce the triceps or other muscles?
The whole idea for my approach is to address the layer of fat in the most even fashion. So I don't like to try to carve out any areas. I try to, wherever I'm working on, is to thin it out very evenly. And whatever is in the background is now going to be seen more because there's less fat over the top. So do I follow contours of the arm? Do I follow across the delt and stuff? Yes, but I don't sit there and carve it out to make it look like a fake muscle. So, I always encourage being in great shape and then dealing and having me deal with the fat that's stubborn, that's not responding to you working out. So that way, when I do thin it out, it's bringing out what you've done for yourself in regards to the musculature.
Another good question is there a difference between a fat transfer and a BBL or a Brazilian butt lift? Or is it the same thing? Yeah.
Have been terminology and it just stuck, and now it's kind of like the same thing. I mean, could a Brazilian butt lift, be a implant, like a buttock implant could give you a Brazilian butt lift? That is possible, but specifically the BBL and Brazilian butt lift means that it's a better butt due to fat being moved from one place into the buttock area. But we've moved I try to move away from that term because it's like, what does it mean? My butt looks like it's from Brazil or something, like it doesn't really tell you anything other than it's just associated with fat transfer. So, we've migrated into our ABL, right? So our awake butt lift, because it's really unique that we do it in the awake fashion, which is super safe. But it is lifting the butt, right? I mean, the butt does look more lifted. It's not physically lifting it up like this, but it's filling it out. It's recruiting the tissue. It's inflating the butt. A lot of times if you look at them, they're kind of deflated. They're a little sad, right? And so you inflate it and it looks happier, right? But
Can you let people know what you mean by awake? they're, are they just sitting there like completely coherent, or what does awake mean to you?
Coffee, no,
What's that?
coffee, wake them up, and then do it.
Yeah.
So it's relaxed, right? So what I mean by awake is that what I essentially mean is it's not general anesthesia, and it's not under IV sedation. So it's not like you're in twilight, like type states. Patients are interacting with me. They get typically a little Vicodin, they get a little Xanax, they get a nice little buzz, and they kind of don't care what's happening, and they're still interacting with me. Some patients are awake the whole time because they just don't get affected by those meds as much as, say, our patient today who was sleeping through over half of it, but she's easily arousable. So when I talked to her and I engaged with her, she would respond to me, but then just kind of drift back off to sleep. So it's just kind of in this la-la state of relaxation, but still breathing on her own. There's no need for supplemental oxygen or any breathing tubes or any support of the vasculature of the blood pressure or the breathing or any of that stuff, because it's all maintained by the patient because they're awake.
And Dr. Justin, why don't you take us through the compression garments, at least through the first month, and how we used to wear them?
I put one next to you, if you want to grab it. The other side.
Oh.
So that one's for the arms, because we have had a lot of people ask and talk about the arms. So that one is the compression garment that somebody would be wearing if they had arm lipo.
Yes.
So if you want to show everyone.
Some patients ask, "Oh, do I have to bring my own garment?" Because there's apparently some practices that make patients bring their own garment. No, we have a full inventory here, and so we always place the patients in garments as soon as we're done, because as soon as I'm done sculpting, compression is the next most important thing. So they go immediately into the compression garment, sometimes 2 garments, depending on the areas. If it's arms and waist, essentially we're getting them into 2 different garments immediately, and they're custom fit. Essentially, we have all the sizes, so that way you're not leaving here with too big or too small. It's like fit perfect. Okay, and for
how long do they wear that for?
Forever. No, but so I say, our protocol is for 2 days straight, all the time. So you go home with the garment on, you keep it on for 2 days. If you want to push it into that 3rd day, because it's about 48 hours, you can do that. You take it off, you shower quickly, wash the garment real quick, and then boom, put it right back on. And you want to spend very little time outside the garment. I shoot for 2 weeks minimum, ideally 4 weeks, and then even moving into waist trainers if it's the waist. If it's for the arms, I typically push hard for 2 weeks, and then you can start moving away from it. And usually by 4 weeks, you're not wearing any garments, unless it just feels good to have some support, like a workout shirt or something like that. If you're doing a lot of kind of impact activity, it feels a little weird just with movement. So having a little support sometimes is nice, but it's not mandatory. So anyway, garments for the arms, right? So essentially, this comes down past the elbow, because I go all the way down to the elbow, so you need to be, is this one past the elbow? It seems kind of small.
It's an extra small. Because you get all your patients that small, right? It's an extra small.
So this will come past the elbow, and it's important because if they're too short, then it's just going to ride up into where I worked, and I don't want to cause any indentations, and we want to compress. I mean, that's the whole important thing. So it goes all the way across and kind of up into the armpit. If we did the front bra roll, so the arm and then into the front bra roll, so this area, it essentially would be in this zone. We put extra padding in there to get good compression across that whole front area, because it's a little bit of a challenging area to get compression, because you don't want to tourniquet the arm and then all of a sudden your hand goes numb. So that's the challenging part on the arms, is you can't squeeze too hard because it causes problems with the hands and fingers and stuff. Other than like the abdomen, because the abdomen you can kind of squeeze as hard as you want, within reason, but you can really crank on it and get away with it. Doesn't cause issues like an extremity would. So we talk about the clips, right? There's some clips in the front. The clips allow for advancement as the swelling goes down. Not so much for the arms. There's not, you can't really, doesn't make them tighter. But if we're working across the back bra roll, all right, I should probably put this down. I don't know if that's helping anymore. But if you're working across the back bra roll, and after a few days you've shrunk down, swelling's come down, and you feel like it's getting a little loose, then you move the clip in, right, and you keep moving it in until it's not tight enough, and then you're moving down into the next size down garment. And that's the whole goal. If you can, you try to get it on the tightest setting and then move into a smaller garment, because that means you're getting smaller.
So how many, like, what's your maximum amount of times that you have sculpted one person? Or say somebody came to you and they already had 2 times a certain area sculpted, and they gained more weight and they want more, they sculpted again. What's your max? Do you have a maximum number of times that you will either sculpt somebody or be that revision doctor?
Yeah, it's usually 3 times. If an area has been addressed 3 times, going in a 4th time is very unrewarding. I've been there, done that, and it produces such little amount of fat. Even if the patient feels like they're big and they're like overweight, typically that layer has been exhausted, and now the fat's coming from internal, and so it doesn't, just because they're kind of big, they come in, they've had lipo 3 times, and they put on a bunch of weight and they feel bigger, it doesn't mean that it's in that layer anymore. So there's, I've had a number of patients come, and they've had it done 3 times and they want more. I mean, I have a couple of my patients that even though they look great, they want to be smaller, and they're trying to push me into doing more in the area, and I'm like, no, because it doesn't. There's the point where there's no more fat there, even though it feels like it's thick. It's like scar tissue and connective tissue and things, and so going into those zones can be very unrewarding if it's been done 3 times, right? I mean, if it's been done 3 times outside of me and it was done very little each time, then that's a possibility. I mean, I always make that determination with a consultation. You gotta, it could be a patient who still has some residual fat because it wasn't thoroughly sculpted. That is possible, but a lot of times it's very little.
Here's another good question that says, should you get Precision Sculpt 360 before you plan to get pregnant or after? Great question.
Pregnancy, right? If you're going to get pregnant in 6 months, I'd say wait on it. But I've had a handful of patients come that plan on getting pregnant, meaning that they plan on meeting a guy and they want to get pregnant and they haven't been there yet, and so they're going to get the body that gets them that guy that gets them pregnant. Within a time. So if your plan is to get that hot bod to get you that guy, then that's but
That's just got a stream of guys now.
out of shape, and you go and get pregnant, right? And you stretch all out, and you're set up for more damage to your body, right? If you're in great shape and you get pregnant, right, you typically come out looking better than the person that was out of shape and gets pregnant, right? They get more stretched and all that stuff. So in theory, right, and I mean, it's not even theory, but I'm getting them into a better shape, better state. They're smaller, right? And so when they get pregnant, they're going to stretch less, so to speak, because they got less on board, right? So I always think it's a great idea to get in great shape as possible, do the lipo, the precision sculpt to get them down, and then if they get pregnant a year later, awesome. That's fine. In fact, they're kind of in a better state to go through pregnancy and come out on the other end potentially looking, acceptable, or still, even though we can do lipo after pregnancy, that's fine too. I'd say if you can do it, get it early. Get it done before all that. But not like 6 months. We'll just get.
Yeah.
What about if you have a patient, and we can see on your Instagram that you have bodies of all different sizes and shapes. So say you have somebody who comes in who's, considered in that obese section, has a lot of extra fat to take. What's the maximum amount? Is there a maximum that you can take in one sitting? How do you approach that patient?
All sizes, and really skinnies with just tiny little bit of fat, and some morbidly obese patients with massive amounts of fat. So the recommendation is 5 liters. So that's like 2 liters of Coke and a half, right? Of total volume taken off the patient in 1 second, right? So total volume meaning everything from the So
So it's like 2.5 of these?
fat, right? So that's 5 pounds of fat there. So each liter of fat weighs about 2 pounds. So that is a little over 2 liters of fat, right? Okay,
This.
that's about 2 liters of fat, somewhere in there. So total volume in 5 liters. So with 5 liters is a certain amount of fat, right? However much fat is kind of comes off in that section. So some people I'm getting 5 liters off, and they might have 2 liters of fat within it. They might have 3 liters. They might have a liter and a half. They might, it just depends on the nature of the tissue. But if someone's coming really obese and they have a lot of fat, then we divide it into sessions to keep it nice and safe. So you come in, say on a Monday, and I do all the front of the abdomen, and I take good 5 liters off here, and then they come back 2 days later, which is totally fine. Come back 2 days later, and we work across the waist, and then we can take out off another 5 liters and get to that end point, reasonable end point, in the safest fashion. If you were to do more than 5 liters in one session, the recommendation is to do that in the hospital in a monitored setting and stay overnight, because there is a higher risk for having vascular instability, like your blood pressure is all over the place. You might need resuscitation and fluids. It's more of a traumatic blow to take more than 5 liters. Now, is the 5 liters like a set number? It's a recommendation, and you can kind of play with it a little bit. I find that in the awake setting, patients are a lot more stable, and they're able to drink during the procedure. They're a lot more they're breathing on their own, and so can they handle a little bit more volume off of them? Yes. I mean, you've done it so many thousands of times now. I see it's a lot more stable and a lot more healthy for the patient. They're a lot more stronger throughout the whole procedure, as opposed to being put under general anesthesia. And that's where those 5 liters comes into play, those general anesthetic situations where they're already a little unstable from the anesthesia standpoint, and then you throw on a massive volume removal, and then they become more unstable. In the awake setting, different story. So that number is, we have some flexibility with that number a little bit.
And how do you know when to do lipo on the abdomen or do a tummy?
Tummy tuck, is that what you said? So I have lots of patients come to me because they don't want tummy tucks, right? Not everybody wants a tummy tuck. And everyone, they don't want the scar. They don't want the general anesthesia, the downtime that comes with it. So I see a lot of patients that most other surgeons would just offer them a tummy tuck, and that's it. So tummy tuck, if you have loose skin, hanging skin, or you have some looseness to you, that you pull it up and you show that you make it really tight, and you're like, I want that look. Well, then you gotta venture into tummy tuck land, because you gotta remove skin and stitch and pull that sheet tight, so to speak, to get that type of look. If you're looking to get a smaller version of what your skin looks like now, then you can entertain a liposuction approach. But not just with any surgeon. I mean, essentially with us, I take care of a lot of patients that the way I sculpt gives them a nice appearance, even with their sort of loose tissue. Where other surgeons just excavate everything and it just leaves them hanging, and so that's why they don't even offer that. There's only a tummy tuck, because essentially their approach to sculpting leaves it totally deflated. So if you got extra skin and you want the skin removed, you got to entertain tummy tuck. If you're okay with the skin and understand that the way it's looking is going to be kind of a smaller version of the way it looks, then boom, we sculpt you.
Yeah. I think we may need to do another Dr. Justin day, because he's so popular today.
I get chatty, talking.
I don't even know.
What about fat transfer to the breast and a lift at the same time? Do you do that?
I love doing that. You know, you're asking me like you don't know. I love that. That's good. Yes, I love doing that procedure because, and again, we do that all awake here in the office, which is awesome because I can spend a lot of time getting it perfect. So, you know, lifting the breast is great, right? You lift it, you get everything in position, the breast is sitting in the right place, but if you're lacking volume, then you're like, oh, okay, great, you know, small lifted breast. If you can add fat and add the volume at the same time, now you get the fill and you get the lift. It's great. It's not the same as a lift with a breast implant, which you can get a lot more fill volume, but you know, most patients of mine now don't want implants. So, which is great. I love the fat anyway. It's super, super safe.
And if people wanted to maybe have you look at them and see what you recommend, are you offering virtual consultations?
Oh,
We can't hear you. We can't hear you.
I don't know. Maybe you got to turn it up.
And now we can hear you, but Ashley's doing something over there.
I was just putting our phone number in. Sorry.
Oh, virtual consults. Yeah, the virtual consults
Yeah.
are great. You know, honestly, like they were as an in-person consultation. Actually, I just talked to the patient, the surgery today that we did earlier. I met her virtually and had all contact virtual until today, which was in person. And virtually, we determined that she's a good candidate, right? I know I can help her. I know I can sculpt the areas. But then when she came in the day of her surgery, now we all the details of where I'm going to be sculpting. I mean, we had the general area, but exactly how I'm going to tackle this area, how I'm going to tackle that area. I map it and draw it all out. So we get the full picture essentially the day of the procedure, but we were crystal clear on where we were going to be working and had a general idea of the improvement that we were going to get for her. But now I was able to really kind of lay it all out. But virtual consults are great. You know, it's just as effective as being in person, and the patient's at home and they don't have to worry about driving in the traffic and all that stuff.
Awesome.
Okay, awesome. You guys can go on our website at idealfaceandbody.com and fill out the virtual consultation request form, and our office will be in touch with you to go ahead and schedule.
It's idealfaceandbody.com.
Yeah, www.idealfaceandbody.com.
All the drop downs, it's as simple as, you know, it can be. It's great. I love it. And then you
Bomb.com.
and then I get to see it.
Yes.
Awesome. Well, thank you very much. It was very informative.
You're so insightful, Dr. Justin.
And cute. Super dreamy.
Next time.
Thank you.
Bye.
Bye. Thank you guys all for watching.